welcome everyone who is joining us today. If you're having any issues hearing or seeing Dr. Bain's screen, please just put a little message down there in the chat and we will try to help you out here. I do want to take a moment just to thank everyone involved in getting this webinar organized. So it's been a collaboration between 3 different groups: the Cleveland Clinic, the Joe Niekro Foundation, and Niekro Corporation. Just a little bit of background on the Niekro Foundation. They are a group committed to supporting patients and families, research, treatment, and awareness of brain aneurysms, AVMs, and hemorrhagic strokes. They provide education on the risk factors, causes, and treatments of those conditions while funding the advancement of neurological research. So we thank them for their collaboration in this. And then as you see on your screen here, we have a great speaker with us today, Dr. Mark Bain of Cleveland Clinic. Dr. Bain is a neurosurgeon at Cleveland Clinic, as well as the head of cerebrovascular neurosurgery and endovascular surgical neuroradiology. He is also the acting cerebrovascular neurosurgery fellowship director and associate program director for Cleveland Clinic's neurosurgery residency. With many years of experience, both in practice and as an educator, Dr. Bain is an expert in minimally invasive cerebrovascular neurosurgery. So we're glad to have all of you with us. Thank you, Dr. Bain, for being here. And with that, we will turn it over to you.
Awesome, great, thanks, Heather, really appreciate it. I hope all you can hear me okay, and I'm gonna share my screen and we'll get started here. All right, everybody, I'm going to slide mode here. Everybody see that okay? Heather, you can see that?
I sure can.
All right, perfect. So first, I'd just like to say thank you to a couple of people for organizing this or groups for that matter. And thank you for the Niekro Foundation for setting this up. It's an honor to be speaking during Stroke Awareness Month. Really just want to say thank you for everything that the foundation does for stroke survivors and for practitioners that are helping to take care of people with stroke. It's an honor to be talking. And also thank you to Niekro Corporation for giving me the opportunity to talk. So we wanted to maybe change gears a little bit here and talk a little bit about intracerebral hemorrhage, or ICH. A lot of time we spend talking about aneurysm ruptures and AVM ruptures. This is sort of a good time for this as intracerebral hemorrhage is really sort of gathering momentum as a field, and particularly the surgical, minimally invasive evacuation techniques. We've been doing a lot of these techniques over the years here in Cleveland, and a lot of other centers are doing this as well. And I wanted to take some time to sort of educate everybody on sort of where we're at, a little bit of the road that we've taken to get here, just so everybody's on the same page, and hopefully can have a nice discussion after the presentation. So these are my disclosures. Of note, I am an enriched trial PI. That's a minimally invasive trial that is being funded by Niekro. I do do educational talks for Niekro, but I'm not a consultant for Niekro, nor do I take any money for Niekro. So I just wanted to introduce the Cleveland Clinic. Most of you on the call have probably heard this. This is like a beautiful day in Cleveland. This happens maybe once every, I don't know, maybe a couple of years we get a day like this. Usually there's a lot of snow on the ground, but this is the main campus where we have over 1,300 beds. This is the new medical school right on sort of the banks of Lake Erie here. And this is housing all of Case Western and Cleveland Clinic medical school, nursing schools, and dental schools. Really good collaboration at this campus, and that has just been built. Right now, it's our overflow for COVID patients, and luckily we have not had to use that. And this is a map of northeast Ohio, and we have a fair amount of hospitals, regional health centers, family health centers, and health and wellness centers throughout northeast Ohio. And a lot of these centers will refer patients with aneurysms, AVMs, and specifically with intracerebral hemorrhage. We'll talk a little bit we'll talk a little bit later in the talk about how we sort of coordinate that and how we manage that. We have a very robust auto launch system here in Cleveland. And what that means is that if there's a diagnosis of aneurysm or subarachnoid hemorrhage, AVM, ICH, the critical care transport team automatically will basically send transport to these hospitals, whether it's another hospital outside of our hospital system or in our hospital system, before they even contact us as physicians. So the patient, just to waste as little time as possible in getting patients to the proper care that they need and deserve. So we have a very robust auto launch system, and that really is helpful because it really cuts down on our time to treatment, and it gets patients where they need to be, in the proper amount of time and in the proper place. We also have a mobile stroke unit. Peter Rasmussen was integral in getting us one of the first in the nation, these mobile stroke units, and we're building our second unit now. That unit is roaming all over the city, picking up stroke patients. We do get a lot of intracerebral hemorrhage on the stroke mobile. They initially think they're signs of ischemic stroke, and then we pick the patient up, do a CT scanner, which you can see right in that picture there, and sometimes it's intracerebral hemorrhage. And I'll show a case a little bit later here where that really benefited a patient having that rapid diagnosis on the ambulance. So I wanted to talk a little bit about the problem, and I really commend anyone who wants to take on intracerebral hemorrhage, as a problem and go into this field. It is a devastating field with a lot of bad outcomes at this point. But I think a lot of us that are going into this, a lot of our industry partners and a lot of physicians that go into this and our programs that are meant to treat hemorrhagic stroke patients, we really see that there's a massive opportunity here to help people. One of the things that we see and we think is probably maybe the biggest issue with intracerebral hemorrhage is the initial injury that happens. In a scan like this, there may be nothing we can do because the initial injury of the hemorrhage was so bad. Now, that being said, we do know that hematomas expand. And one potential very large therapeutic window here is to get the hematoma before it expands and maybe prevent some of this initial injury. So I sort of see that as maybe a quote unquote penumbra, like we talk about in ischemic stroke, where we can potentially help patients if we get these patients early so we can prevent this expansion. And then we know that there is this delayed injury event that happens where people will be in the ICU and get perihematomal edema and swelling, and patients will be in the ICU and have just a continued neurologic decline. So I think that's another therapeutic window where we can target. So maybe by getting rid of that hematoma, we don't have to deal with that delayed edema reaction. So, all the clinicians on this call, know this really well, but this is a scan of a patient that came in to our ICU, and you can see the time of admission was, this first CAT scan was about 5:49 in the afternoon. And, you get the phone, the patient's doing okay, maybe has some weakness. And then, 2 hours later, the patient blows their pupil and is in a coma. And that's that expansion that we see. And there's a lot of questions out there, if we would have operated on this patient early or been able to give some type of a medical factor, whether it's reversal of anticoagulation, factor VII, Kcentra, what have you, PCC, would that prevent that expansion from happening? So a lot of questions there and a lot of opportunity there. Sorry, my computer's not advancing. So then we also know that there's this slower, delayed injury or secondary injury that happens. And this is something that really, really, I know irritates me and irritates my ICU colleagues is when we have a patient come into the ICU and, the patient's in the hospital for, 14, 20 days, and there's swelling that's happening. And we're just watching a patient slowly deteriorate over time because of this swelling. And now, if you look at these scans here, the patient's got a ventriculostomy drain in, and we're trying to handle the intracranial pressure that's going on. So I think this is another real big, like I said before, opportunity where we could potentially remove this hematoma, get the patient out of the ICU earlier, prevent the need for a ventriculostomy drain, and get the patient to rehab faster so they can get better. So I mentioned this a little bit in the beginning, but when you look at the pie graph for stroke in general, ischemic stroke is 80% of this, and we've made really, really, great strides in helping patients with ischemic stroke with mechanical thrombectomy. There's just no doubt about that, and that's been an amazing thing that's happened in our field, and we're still sort of dealing with how we're going to take care of all these patients, and because there's so many patients that we're dealing with mechanical thrombectomy now. If you look at subarachnoid hemorrhage, it's just amazing to me when you go to any of our conferences and you look at, you go to basically the exhibit halls and you look at how many devices are being made to treat aneurysms, and it's only 5% really of this overall stroke picture. And we spend a lot of time talking about aneurysmal subarachnoid hemorrhage, but we really leave alone the 15% of people that are suffering from intracerebral hemorrhage. It truly is an orphan disease, and up until probably, I would say, maybe 2013, there were only a few things that were going on, maybe like the MISTY trials and the MISTY technique and things like that were really sort of targeting intracerebral hemorrhage and seeing if we could push this field forward, and not for the sake because we want to do procedures, but to truly try to figure out, can we help people and can we treat people better that have this devastating disease? So there are a lot of trials out there, and I'm going to try to organize these trials for everybody. So first of all, I don't bore you to death by going through all this data, but I want to try to put this a little bit in perspective. So one of the reasons I think that us as surgeons and neurology and neuro ICU as a field have gotten away from surgical therapy in ICH is because if you look at the large trials, specifically the randomized trials that were done for intracerebral hemorrhage, almost all of the large trials have been negative. And it really has just sort of killed surgery for treating intracerebral hemorrhage. If you look at the STITCH trials, I mean, almost all neurosurgeons know the STITCH trial, and it's the main reason why we are not offering open craniotomy for patients that have intracerebral hemorrhage. It really just failed to demonstrate any superiority over just conservative management in the ICU. The MISTY trials have really, I think, have pushed the field forward, although they have, and we'll talk a little bit about MISTY in a second, but the MISTY trials, as everyone probably knows, really overall were negative. MISTY 2 was not powered for efficacy. It was basically looking at safety to see if we could actually safely remove hematomas with a catheter and TPA into the hemorrhage. But MISTY 3 was powered. That just finished a little while ago here at 506 patients, but it was negative overall. But these trials, because they were minimally invasive, I think they did have some trends in them that were very, very interesting, and I think really helped push the field forward. We'll talk about that in a little bit. So based on this, the American Heart Association guidelines for the management of spontaneous intracerebral hemorrhage, remember we're talking about hemorrhage that is not due to aneurysm or AVM, it's usually from hypertension or amyloid or just spontaneous intracerebral hemorrhage. Really the usefulness of surgery is not well established. And so most people, I think, probably around the country and internationally are not treating ICH with any form of surgery. The story changes a little bit when you look at minimal access trials. And when I first got into this field, I didn't think really that there were a lot of trials out there. But when you really start digging into the literature, you actually find there are a fair amount of trials. There are actually, some larger trials, and a lot of them are randomized clinical trials where they're randomized from medical management of ICH to some type of minimally invasive surgery. And if you look at these trials, the overall trend is that if you do minimally invasive techniques, whether that's using an endoscope or using an endoport, and then use some type of an aspiration device, and usually if you go a little bit earlier rather than later, all of a sudden things start looking a little bit different, and people were doing much, much better when they were treated with surgery rather than just medical therapy and being left in the neurological ICU. And I always pick out this first study that's here, this our study in 1989. So old trial in the Journal of Neurosurgery, and you wouldn't think an older trial would have much to teach us, but it's really interesting, and I like it because it really mirrors what we're seeing right now. So in this trial, they showed that they had basically a 30% lower mortality rate when they did surgery. They were using this little endoscopic aspirator to remove the hematomas. 40% versus 23% of patients showed a good outcome with minimal or no symptoms with surgery versus medical management. So doing much better with surgery. And this sounds very, very obvious, but people that had smaller hemorrhages, so less than 50 cc hemorrhages, when they were operated on, had a much better functional recovery. And people that had larger hemorrhages, greater than 50 cc's, which we all know is a fairly large hemorrhage, they were able to show better mortality rates, but they didn't show any difference in functional outcome. So it just makes sense. Smaller hemorrhages, if you took those out, functional recovery. Larger hemorrhages, you get survival, but you couldn't really show much of a functional benefit. And we have also kind of known this as well. Some of these deeper hemorrhages in the putamen and the thalamus, the patients did worse than if they were more cortically based. And this is very interesting too, because with their technique they were using, 15% of the time they were getting a 90% clot evacuation. So very small percentage of the time they were getting a large amount of clot out. Right now we are doing way better than that. And I'll show you some of our data where we're getting higher than 90% clot evacuation in almost every patient with our techniques. So we're doing much better than they are surgically, but they still have these great outcomes. So this is a very interesting trial for me. There's a lot of other data out there and evidence for minimally invasive surgery. So Wang's trial in 2009, it was a randomized clinical trial for 377 patients. It was minimally invasive techniques versus medical management. And it's interesting to me here, they were doing small hemorrhages. If you look at some of the hemorrhages we're targeting now in our current trials, like the Enrich trial, we're going all the way up to 80 cc's. So they're doing very small hemorrhages, which I think when I first started doing this, a lot of neurologists were telling me, you know, those are small hemorrhages. Why would you ever operate on those? Those people get better anyway. Well, they were targeting small hemorrhages, looking for that functional outcome. And these were in the basal ganglia too, deeper hemorrhages. So this is their technique. They were placing, under CT guidance, they were placing this catheter. They were aspirating blood with the catheter, and they were injecting a urokinase solution to break up the clot. And they would maintain this drainage for about 3 to 5 days, very similar to a MISTI technique, which we'll talk about in a bit. And here's the system they used. I always show this picture because I think it's really interesting. You know, they're using this drill. Like I think I could find one of these in my basement somewhere. It is not a very standardized approach. Okay, so it's very hard to look at these studies and kind of compare things because everybody was doing different things. And I think that's one thing that we're changing now, and I'll talk about that in a little bit as well. But this is how they did it. And they looked at dependence at 90 days with their craniopuncture, their surgical technique. It was 40.9%, with conservative management, 64%. And that was significant. So people were doing better with this technique. Kim in the Journal of Korean Neurosurgery, they randomized 387 patients. Again, look, these are small hemorrhages, less than 30 cc's basal ganglia hemorrhages. They had the stereotactic guided MIS. They had this Archimedes aspirator and this lytic. So they were breaking the clot up versus medical management. And if you look at their MRS score, 180 days with their minimally invasive technique, their median was 1.2 versus medical management was 3, and that was significant as well. And their Barthel index, the patients did much better. So there was 90.9 versus 62. So just again, patients were doing better in these various outcome measures. They're doing much better with minimally invasive techniques than they were with medical management. And then Zhao has a large meta-analysis that included almost 2,000 patients in this meta-analysis. And it looked again at medical management versus this minimally invasive techniques. And minimally invasive surgery reduced death or dependence as well. And there's growing evidence out there right now. So there's multiple meta-analysis out there looking at all these randomized clinical trials. So in Gregson's trial over here on the left, there was over 2,000 cases. Zhao's trial, which we talked about there, was almost 2,000. And then Jay Mako and Chris Calder at Mount Sinai are doing an incredible job looking at minimally invasive techniques. They looked at 15 randomized clinical trials, over 2,000. And all of these are really showing better benefit to patient with minimally invasive techniques, and also if you go earlier rather than later, so like around 24 hours, don't wait till that edema sort of happens. So the evidence is growing for minimally invasive techniques, and it's showing benefit over other approaches like craniotomy. It's showing benefit over conservative treatment. It's starting to show benefit if you go early, so before a patient deteriorates or expands, get that thing before it causes that initial injury to the patient. We're showing some positive impact on functional outcomes. And I think a really interesting thing too is that we're showing that we're decreasing the length of stay, so it's less cost to the hospital system. It's reduced length of stay overall and also in the ICU. So I think our average length of stay now for our hemorrhages that we're evacuating is under a week, and if we don't, it's almost 2 weeks. So very, very interesting to the hospital system as well. So I talked a little bit about MISTI approach, and I wanted just to cover this for the non-surgeons in the audience and for people that may not have heard of this. The MISTI approach, and Dr. Awad has talked a lot about this and has published this. This is where basically a catheter is placed into the hemorrhage. And you got to remember, when this came out, this was sort of a revolutionary thing that you could put a catheter into a blood clot. Okay, you could aspirate a little bit of the blood, and then you could actually inject TPA into a blood clot. You'd think that that'd be the dumbest thing you could do, because you would loosen up a little bleeding vessel and you would cause more bleeding and the hematoma would expand. But what they were able to show that it actually worked, and you can see the scan here on the bottom of the screen where they were placing this catheter. They were injecting TPA, and you could see slowly over time the TPA would dissolve that clot, and it allowed the clot to come out of the catheter. So it's a very minimally invasive technique that they could use. So MISTY 3, the results were basically presented in 2019. They had 506 patients from 78 centers across the world, really. And their primary objective here was to show or to demonstrate that minimally invasive surgery plus TPA into these hemorrhages for 3 days improved functional outcome by 12%. Increase in MRS 0 to 3 compared to a bad outcome, and they looked at it at a year, 365 days. Okay, and just to cut to the chase, this was basically negative. It didn't show that 12% increase in MRS 0 to 3 or a good outcome, and there's a couple of reasons we think that happened. So their average evacuation rate with this technique was about 69%, 70%. At 3.6 days, okay? And we know now, and at least we think that by getting the hemorrhage out, okay, and not leaving any hemorrhage there, we're benefiting the patient. They were leaving a fair amount of hemorrhage in these clots. They weren't able to get the job done consistently. They had an end of treatment volume goal less than 15 cc's, and they only reached that 60% of the time. So they're only getting the job done what they needed to do 60% of the time. And really what this reminds me a lot of, and to the neurosurgeons or interventionalists in the audience, it reminds me a lot of 2013 when we were doing ischemic stroke mechanical thrombectomy trials, when we were using devices like the Mercy device and things like that we weren't able to get high rates of recanalization, and then we were trying to study these techniques. So we were studying something that was only working part of the time. So of course these trials are going to be negative overall. They weren't getting the job done. It was interesting, though, if you looked at some of the subset analysis, when they were able to get the job done, okay, so in patients here that had end of treatment volumes 0 to 15 cc's, meaning they got a lot of the clot out, the probability of having a good outcome was much, much better than you see if they left a lot of clot here. It wasn't. And the same thing over here. If they got percent of the hematoma removed was around the 70%, you saw a rapid increase in probability of having a good outcome. All right. So basically, get the clot out, get the job done, people do better. Okay. And if you look at the people where they had a less than 15 cc clot size at the end of treatment, they were able to show a 10.5% increase in risk difference in MRS that was 0 to 3 or a good outcome. So basically, they get the hemorrhage out like they're supposed to, people did better. So instead of us looking at this as a negative trial and just hanging our heads saying, okay, we're done, we're not going to do any more work here, this sort of gave us hope that hey, listen, if we have a technique or a surgical technique that works consistently and we're able to get a high volume of hematoma evacuated, well, maybe we can help people, or maybe we could show a better functional outcome. And here are some of the summary of the results. They didn't show a difference between surgery and medical management. They had a very difficult time getting a high volume of hematoma evacuation. I would also say a consistent high volume evacuation. And again, it took time. So I could just imagine, 3-4 days are going on. That hematoma is starting to get some edema, and maybe there's some secondary injury occurring during those times. So if I was designing something, I'd want to get that hematoma out faster. All right. So, but again, like I said, there was a lot of, at ISC, and the International Stroke Conference 2019, a lot of people were looking at this data and say, hey, listen, this is interesting. You know what, I guess we're getting, we may be able to get better outcomes here. We have better surgical performance. And we wrote a commentary in the Journal of Neurointerventional Surgery, sort of comparing this to the ischemic stroke trials in 2013. And we have a signal here. There's no question that a more efficient procedure may benefit patients. So that's sort of the data part of this talk. I wanted to show a little bit of sort of our journey here in Cleveland and kind of how we started. And I think it mirrors a lot of how a lot of places around the country, a lot of centers around the country have gotten into this field. So I initially started doing these procedures using the Apollo device, which Penumbra made. And if you kind of remember how Apollo came out, and for the people in the audience that don't know, This is an endovascular company that made Apollo, and we had devices that were sort of good at getting clot out of arteries, and they sort of took some of that technology and said, hey, can we get it out of the brain too? So we were trying to figure out how to use this device to take these hemorrhages out. And this is a picture of one of our first patients that we did. We have consent for these pictures. And we were doing these procedures in our angio suite. So you can see all of our coil carts over here for treating aneurysms. We were bringing in endoscopic, towers in so we could see what the endoscope was doing. We were trying to figure out how to get our stereotaxy with our brain lab right here to fix the patient's head. And to long story short, there was just a lot of equipment that was going on. We were doing angiograms as well. So we do an angiogram and do the surgery. So these things were taking like 3 or 4 hours. And then we would do these procedures, and we were trying to figure out how to use things. So here is a shunt stereotactic cannula that we were putting down a peel away sheath and cutting this off to use. So this is sort of the MacGyver technique of just trying to get things to work. And after all these procedures, we would talk to each other around the country and say, hey, listen, I used this, I did this worked, this didn't work. And here's us putting an endoscope down and through a burr hole. So pretty minimally invasive, just a little burr hole. And occasionally we would get good results. So here's a case that had it was a frontal hemorrhage that blew into the ventricle. And this is the endoscope going down. This is after we took the hemorrhage out. This is the Apollo device. We can look around the ventricle here, and you can see where all the blood was. You can see the ventricular veins there. And we were able to get, hematoma evacuated from the brain. And it sort of started saying, hey, listen, we can do this. This not crazy to put these endoscopes into hematomas and take the clot out. So we were having these cases. This is one of our first cases we did where a patient came in with a pretty large right frontal hemorrhage. And then we were doing angiograms. The last thing that we wanted to do was to put a endoscope down into a hemorrhage that had an AVM there or something like that. So we were doing angiograms. You can see the shift in the ACA vessels there. There's just a ton of mass effect from this clot. There's the other side showing the shift. And these are kind of the results we were getting initially. So, we would put we would get some of the hemorrhage out. I think this is about a 50 cc reduction. The patients were doing fairly well because look at the mass effect here, pre versus post. The ventricles were coming back and the shift was better. So our patients were waking up. And so we were doing these things called passes, where you're putting the Apollo down and aspirating, and we reduced it by about 50%. And that was our Apollo experience, but it was a little frustrating too. We were getting like 50% clot evacuations. They were taking a long time. And someone mentioned to me, we were using these NICO brain path tubes for removing tumors and things like that. And so this is our first patient. Let me go back real quick, and then I think someone has a question here. I'll take time to answer that. So. This was one of our first patients, a 73-year-old that had this large temporal hemorrhage. You can see it goes all the way down to the temporal pole, comes all the way up here. So you think, based on this scan, this person's probably going to have long-term aphasia, motor issues. And I think the stars were aligned for us here, because this was the mother of one of our anesthesiologists that worked here in Cleveland. And so this patient came in and she had altered mental status. She was basically globally aphasic and she had right-sided hemiplegia. And we took her and did a brain path clot evacuation on the day of admission. I can't remember the timing on this one, but I think it was under 24 hours. And it was funny, on post update 13, she had a little bit of movement in the right arm. And then we followed her, and week 10, she was talking. She was moving the right arm about 4 out of 5. And this is her follow-up, about 10 weeks, I think this is about her 6-month follow-up. Let me play this for you. And you can see her moving this right side. And she's, I don't have the video, the audio on here, but she was talking fluently. And I'll tell you what, after this case and this recovery that we saw, we never have a problem getting an operating room for anesthesiologists, because they kind of believe in this approach. And so it's really nice to be able to show that. So I think somebody had a question, if they can speak up.
Hello, can you hear me?
I can, yes.
I'm not a doctor or anything. I'm actually a patient. I actually had a ruptured AVM 3 years ago. So can you see me?
I can't see you, but I can hear you.
Okay. I don't know why my things are working. Hold on. You said if you remove the hemorrhaging, then it doesn't cause a stroke, or?
Well, so no, so when we have bleeding in the brain, I think just by a definition, we consider that a hemorrhagic stroke. What we're talking about here, though, is by enacting some form of a procedure, some form of surgery to remove that hemorrhage, okay, before it can cause other injury to the brain. Okay, so we want to remove it before it gets larger and causes more damage, or before it causes other problems, like let's say seizures or swelling and or things like that. So that's what we're talking about. It's still people that we're talking about here have still had a stroke, but what we're trying to do is mitigate the effects that hemorrhage or that bleeding is having on people. Hope that answers your questions. And I'm going to move on here a little bit from this picture. So
Yeah, and I guess it's nice to actually see someone like that, because when I was in brain rehab, after my brain bleed, I couldn't stand or move around or anything. I couldn't even sit up straight because they had removed my brain flap on the right side.
right, and that's an interesting point, and I'll talk a little bit about that. We have not removed a bone flap or done a big decompressive hemicraniectomy or remove a bone flap for a hemorrhage since we've been doing these minimally invasive techniques, because we can put a tube down and we can take the hemorrhage out, which I'll show in a little bit, and that decreases the swelling and the pressure, and we don't have to do these big operations. So you're right, it is good. Now I don't want to, and I'll talk a little bit about this when you see our results. Not every patient we're operating on has an amazing outcome from this. So I don't want everybody on the line here to be like, oh, this is a 100% miracle. Every patient that gets this procedure is going to do perfect. That is not the case at all. But there is a signal in here of patients that do extremely well from getting this hemorrhage removed. And that's where our work is right now, is to try to figure out who these patients are that we can really benefit. Because right now, it's sometimes it's frustrating. We have almost the same patient, the same looking hemorrhage, the same location, and then in one patient we remove the hematoma, and or in both patients, sorry, we remove the hematoma, and one patient does very, very well, and the other patient doesn't get that benefit. So we're trying to figure out why that is. Is that a genetic thing? Was there higher pressure? Was there a delay in time? A lot of things to work out, and that's a little bit of what we're talking about here. So I would say that the challenges right now for our current approaches are that we have to wait time, like I showed you in that Misty study. We have to wait, it was taking 3.6 days to get the hemorrhage out. And in that trial, they were so scared of putting a catheter down into a hemorrhage that could bleed, they would wait for clot stability. So remember what I said before, maybe that hemorrhage could expand during that time and the patient could do worse. So I think requirement of clot stability is not something I want to do. I do not want to wait, okay? It's difficult to address active bleeding. Let's say you put that catheter down and you start getting bright arterial blood out of there. How do you deal with that? You can't. And I think other factors to consider, and this is just what I was talking about, the timing of the intervention. When do we do this? Do we do this early? Do we do it late? What's our technique? Is it endoscopic? Is it endoport, which we'll talk about? What patient should we be doing this on? The technologies. And I think one of the things that Nico's done well, and some of the other our industry partners have done very well, is insist on training and education. So it's to standardize the technique so that we can make it better and we can study it. One person's not doing this, the other person's doing this. We can have a standardized technique across the board. So that kind of brought us to what is this ideal surgical procedure? So this is what I want. And I think this is what a lot of the interventionalists and surgeons right now want. We want to be able to go early, okay, prevent that initial injury. We want to maximize the clot removal. We know that patients do better, like I showed in that Misty 3 data, that basically we get the clot out, people are going to do better. We want to, of course, minimize the injury to the brain when we do surgery. That's why I think craniotomy doesn't work, because we're going down and going through normal tissue or hurting normal tissue to get to the hematoma. We want to be able to get hemostasis to prevent bleeding and minimize rebleeding down the road. So this is something this is what we want. This is the Holy Grail. And remember, this is the main thing, okay? Maximal and then safe evacuation matters. We want to get all that clot out in a safe way. So this is where we kind of landed, and a lot of people have, is with this brain path, minimal access surgical approach. This picture over here shows, this is the port that we're operating down. This port is about 13.5 millimeters across in diameter. And then this is the obturator that this goes inside of here, and then this gets inserted down. I'll show you a picture of that. And this is designed as a minimal access port to displace the fiber tracts across. So we're using a trans-sulcal approach, meaning that we're using the wrinkles of the brain for this cannula to go down the wrinkles and just spread instead of damage those fibers going across them in a perpendicular fashion. Go parallel to the fibers and trans-sulcal. We're using stereotacty to place this into the hematoma, typically in the long axis of the clot to remove the hematoma. We're not using DTI imaging as much anymore. We were doing that initially to look at the fiber tracts, but we're not doing that as much because a lot of the hemorrhage approaches tend to be the same, either frontal, side, or back. And then we're either using an exoscope for visualization, which is a camera that looks down the tube, a microscope, or I'll show you some things that we're doing now where we're just using our little loops and a light source called the Novus, which I'll show you in a little bit. And we're able to actually operate down these tubes and get both hands or instruments down there so we can actually coagulate and aspirate. So it's basically like we're doing surgery at the bottom of this tube. So this is what this looks like as the port is in the tube here. And so then when you get to the target, this comes out. Here are the different tube lengths that you can use. And this is what it looks like all together. So it's a small incision, a very small craniotomy. I would say I'm about to the size, maybe a little bit bigger than a quarter now to make a craniotomy. So very, very small bony opening instead of a big flap that's there. There's an exoscope here for visualization. And then this is the brain, the wand here. And I think someone is making a comment here. Let me see if I can pull that up. And it says, one of our local neurosurgeons believes removing the hematoma removes the tamponade effect, allowing for increased bleeding and midline shift. And what are my thoughts on that? I think that that can happen. And I think when you remove that hematoma, we published a paper that showed that in our series, 65% of the time, we saw an active bleeder bleeding when we removed a hemorrhage. So maybe that's what we were doing. Maybe we were taking the clot off that hemorrhage, the hemorrhage and the clot off that artery, and it was causing more bleeding. The beautiful thing about this approach, and what all approaches should have, is the ability to stop that bleeding. So I'm going to show a case in a little bit where we're actually targeting active bleeders right now that we think will lead to expansion, and we're able to coagulate that and stop that bleeding. So I think that's a great question, but that's why we need to have the ability to coagulate things when we go in there, because you'd hate to do that if you couldn't stop the bleeding. I totally agree with you. I don't think it exacerbates the midline shift. I think it by removing the hemorrhage, it actually makes the shift better. So this is the approach. Let me advance slides here, and then the real big thing is we want to minimize this injury from surgery. And so there's a couple of different ways you can do things here. And when I first started doing this, I probably didn't believe this as much, but the more I do this, the more I see the benefit of this. Let's say your hemorrhage is down deep here and you have fiber tracts. You can make a couple of choices here. You can go right through the cortex and just go right through here. The person's had a hemorrhage, let's just go through there and it'll be fine. Or, you can use a sulcus, and the sulcus, the only thing you have to go through then when you're using the sulcus are these little U fibers at the bottom of the sulcus. And you look at the distance of brain you're going through versus this. And also, if you're going parallel to these fibers, you're not going to be damaging them much. I think it makes sense. Try to do as less, basically the minimal amount of damage you can getting to the hematoma. And there's cases where these cases have been done awake and for tumor surgery and things, and people are totally fine as these tubes are going down. So I truly believe it's a minimally invasive, safe approach. The secondary thing is once you get to the hematoma, you want to be able to remove the hematoma safely. When I first started doing this, I think I was a little bit arrogant about this, and I was putting big suctions down and just, like you would usually do, and trying to remove, the hematoma on all one big thing, and, just suck it out and be done. What that does is it causes a lot more bleeding you have to deal with at the end. But then the other thing is, I was thinking about this, we're talking about, millimeters maybe. Let's say this hematoma is right near the cortical spinal tracts or the motor fibers, and you just slip with your sucker, and it's a big sucker, and you touch that, and you take half those tracts. That patient's, the patient, they may not know it. They may have been, hemiplegic going into the surgery, but they may not get that recovery later because of that move that happened in the operating room. So by using this device, the Myriad, which I'll show in a little bit, it has an aspiration port here that you can control with your foot pedal. So you can, the harder you push, the more it'll aspirate. And then if you get sort of held up on a big piece of clot, you can activate this little chomper that will finally kind of cut the clot. And so you can very, very finely remove the blood clot without damaging the walls of the hematoma or the walls of the brain, which I think is important. So you got to be able to get the job done in a safe way. There's software out there. This is Synaptive software where you can look at fiber tracks and you can do a lot of preoperative surgical planning. We're moving to a situation now where we're trying to do this fast. So we're not using some of this stuff as much, but if you have another lesion, let's say like an AVM or a cavernous malformation or a brain tumor you want to use, you can use this software. Initially, we were using this for hematomas and tumor, but you can even put the tube on here and you can see what tracks you're going to be going through or what sulci you're going to be going through in the brain. And then you can also plan your craniotomy sites. You can tell how big you want to make your craniotomy so that you can wand this, because you do have to do some wanding of the tube to access a large hematoma. I would say that a lot of times there's so much pressure in these hematomas that a lot of times they'll just deliver themselves to you as you put the tube down. But here you can see, looking down the tube, you can see what you're going to be accessing and what you're going to be removing. So kind of cool surgical planning tools that you can use. This is a case, so I'm going to pause this real quick. I want to show people. So what we do in this is we have the skin opening is only a couple of inches big, and the bony opening, again, like I said, is maybe a little bit bigger than a quarter, maybe a couple inches, depending on how, the access you have and things like that. You want to use a sulcus, so we open up the pia a little bit here, and that allows us access to the sulcus, and then we place the tube down that groove, okay? So if I start playing this, what you'll see, another important thing is that we only open the dura up a little bit, so only enough to allow the tube so the brain doesn't herniate out and kind of strangulate itself around the dural edges. So as we kind of open this pia, what you're going to see is this tube is going to come into place, and the first thing you're going to say, I know, is, oh my God, this thing looks huge. It's going to damage this vein, no question about it. And the first time I saw this, I thought the same thing. Look at the vein over here, about 2 o'clock in your screen here. Look at it stretching that vein as it's going down. I thought for sure that vein is going to rip. But you put the port down, and there's the hematoma. It's very clear visualization of the hematoma. It's almost like a grape jelly consistency. This is using suction to remove it. I use the Myriad now. And you can see how dry this case is. You can look around. You can coagulate things if you need to. Then you pull the tube out, and there's the vein. And so I think that just shows you that it is very gentle to the surrounding structures. And the only brain that you went through was this little bottom of the sulcus here to get to the hematoma. So I think a very, very cool procedure. The other thing is, remember how swollen that brain was in the beginning. Look at how it's falling away from the dura now. You've already decreased the intracranial pressure that's there. So very cool. The next case, this is one of the first cases we did, and this is where we put you can see the tube going down. I show this. Watch when we remove this obturator. Watch how hard or how fast the hematoma comes out. Look at this. We didn't need to do anything here. The hematoma just delivered itself, and I was amazed when I first saw this. It actually scared me when I saw the hematoma coming out that fast. I thought we'd hit an artery or something, but it just showed me how much local mass effect and local pressure there is on the surrounding brain tissue. And for me, this is powerful. Getting this pressure off the brain, it has to do some good for the brain. I can't imagine leaving that pressure there is doing any good for the brain. So it's kind of an eye-opening moment for me when I saw that. And these are the results we're getting. Like, I showed you some of those early results where we're getting part of the hematoma out. This is what we're getting now. So, and I think this is a perfect hemorrhage to be targeting. If you look at this, I call this a good hemorrhage or a respectful hemorrhage. It's sort of layering here on the posterior limb of the internal capsule. So for the patients in the audience, this is where all the motor fibers are, and it's not blowing into those areas, damaging it, just sort of respecting that tract. And people might be weak because it's putting pressure on this. And so we kind of go down here, and look at this, we're able to remove this, and there's that fiber tract that's come right back. And you can see it right here. It's being pressured, and then it comes back. And I think this is a perfect case for this, where it's the pressure that's causing the deficit or the weakness, not that it's destroyed that area. There are other techniques out there. This is the scuba technique that Dr. Kellner and Mako in New York at Mount Sinai have done. They use an endoscope instead of that big port. It's a little more, a smaller access, but it was a little bit more tricky to do. So they had to develop the scuba technique where they put this port down, they remove some hemorrhage, and then they actually infuse saline and operate underwater to open this up. And then they're able to look around and get more of that hemorrhage out. But here's the data that we have now. If you look at the brain path publications, this is using the brain path tube that I showed. If you look at the volume reduction across the board, it's either high 80s or over 90% of the hematoma we're evacuating. If you look at ours in our first, I think it was 18 patients, it was about 98% evacuation. All the clots were coming out. The scuba data that's coming out, that's Dr. Kellner and Dr. Mako, they're getting up to about 88% now. So they're getting better and better. Their initial studies were showing about 50%, but they're getting the clot out now too. So we're getting better at these techniques, and we're getting these hematomas out, which we all know is important. And again, these are just some pictures of the clot. This is one of Kellner's clots that he took out where we removed this large hematoma. This patient did extremely well. We can use ultrasound to look down the hole to see what kind of a resection that we got. And I already showed that other picture. So the other question here, and I talked about this a little bit before, is does time matter here? Okay, is it better? You know, we all know an ischemic stroke with mechanical thrombectomy, or even with aneurysms. You know, we want to treat aneurysms early to prevent them from re-rupturing. If we do this sooner or faster, do patients do better? And we don't necessarily know that, but Barbara Gregson looked at this meta-analysis. I mentioned this one earlier, and in that analysis, they looked at different time points, so under 8 hours, 12 hours, 24 hours, and if you look at this. This is the under 8 hour group, all these trials. And if you look at the odds ratios here, these people were doing much better. It's an odds ratio of 0.59. So almost half these patients were doing much better if they were operated on early, under 8 hours, rather than waiting, so less than 24 hours or less than 72 hours. So that got us thinking a little bit, man, maybe we should be doing this early, like we do mechanical thrombectomy, to get this thing done as soon as we can. And then the other thing we know is we do have predictors of expansion. So I don't know, in the audience, if people have heard of spot sign. A spot sign is something when we get a CAT scan and we use contrast, so we get a CT angiogram, and we'll actually see a little dot of contrast that is actively leaking from a vessel into the hemorrhage. And we know, based on some of the size of the spot sign, how many of those things that we see, that predicts that the hemorrhage is going to get bigger, okay? And to this point, we never really wanted to get involved with the spot sign for a couple of reasons. One is it's active bleeding, so we never were crazy enough to go stick a small tube down and then get bleeding coming at us because we couldn't stop it. We'd have to do open surgery for that. And if you look at how people do, this study shows that look at the even small hemorrhages. So this is the volume of your hemorrhagic brain lesion, like even 5 cc hemorrhage. If you have a spot sign, this is the probability of a poor outcome. It's almost 90%. And that's for like a small hemorrhage, okay? So people that have spot signs and their hematomas expand and they do much worse. So we know hematomas expand. We know we have some parameters that can predict the expansion, okay? Like spot sign, swirl sign. You see these hemorrhages that have like a fluid level in it, or you can almost see the hemorrhage moving around. We know that patients, we know that patients do better if they're operated on early. So why aren't we doing this all early? Well, there's a couple things, but the biggest thing is the fear of intraoperative bleeding. We never wanted to put one of these small tubes down and get into bleeding. And we all see these studies where people show these spot signs predicts intraprocedural bleeding. So we get, these people, this is what a spot sign looks like with these little hemorrhages here. And then we go and take the clot out, and all of a sudden the post-op scan looks 10 times worse than the pre-scan because we couldn't stop the bleeding in the operation. So we wanted to look at this. So we did a multi-center retrospective study where we looked at our patients we were using BrainPath on, and we were calling this ultra early because it's under 8 hours. That is ultra early in the world of intracerebral hemorrhage. And we found 22 patients at our 4 centers. And if you look at our data here, the time to surgery in minutes was 342 minutes. That was the median. We got about 95% evacuation in under 8 hours. So we showed that we were able to get the blood clot out if we did it under 8 hours. That wasn't even known yet. Is it safe to do? Is the hemorrhage going to reaccumulate? Well, only one patient out of those 22 did for 5%. And that was in a patient that had end-stage renal disease, which we know can cause bad platelet dysfunction. So we did re-operate on that patient, but I think that was because of the medical problems they had, not so much the procedure. Our 30-day mortality was a 14%, which is actually pretty good when you look at intracerebral hemorrhage. And our median discharge GCS was 14. So these people were awake, responsive after the procedure. So based on this, we do think early evacuation is safe with this approach and this technique. So I wanted to show this case. I mentioned this early. So, and this goes back to the question that was asked earlier regarding, if we take the tamponade effect off that vessel, will it cause bleeding? So this is a patient that came, a 77-year-old. This patient got randomized to surgery in this ENRICH trial we're doing, and this was under 8 hours. And so this is the hemorrhage. So you can see, fairly small hemorrhage. This probably only measured about 25 cc's initially, so would not have qualified for ENRICH. And then we got a CTA, and what you can see is that this hemorrhage expanded. It's hard to see the hemorrhage here, but it got bigger. And if you look at the medial aspect of this hemorrhage, right there is the spot sign. okay? And before this, you would never want to do a minimally invasive approach, again, for fear of this bleeding. But what we did is we actually targeted the spot sign with the brain path tube, okay? So here's the picture. We put the tube down, and immediately you can see it's a little different than that last video I showed. There's bright red blood, there's active bleeding. So I have a bipolar here, and I have a suction, and I start removing some of the hematoma here. And as we remove some of the blood clot, what you'll see is you start noticing some active bleeding coming from right here. And again, this is the front of the head is up here. So this is the medial side of the hemorrhage, where that spot sign was. And as I remove it right there, see that? You can see that little artery right there pumping that little bit of blood right here. And so you can see that that's the cause of the hemorrhage. This here is the spot sign. So we can get the bipolar down, and we just put it on there and coagulate it just like you would any normal vessel through this tube. And watch what happens. The bleeding stops. All right, we're able to get the clot out. We can put some Surgicel or some coagulant down there, irrigate. And at the end of the procedure, this is what it looks like. Basically, there's no more active bleeding. There's the Surgicel going down and stop any oozing or anything like that. And that's the procedure at the end. Okay. And here's the post-operative scan. All right. So again, to me, this is really powerful, showing this patient may have gone from a small hemorrhage. It already expanded a little bit. It could have continued to expand. We were able to go in early, remove the hemorrhage first of all, and then also potentially to prevent this expansion. And I think this is where we need to be, looking at these therapeutic windows where we can help people. I think we really did help this person. So a couple other things I wanted to show, and the reason to show this is that our technologies now are developing, right? So we first started with this, the MISTI, and then we had these Home Depot drills that we were using. And now if you notice this, we're starting to have more standardized techniques. The technology's getting better. Our industry partners are getting interested in intracerebral hemorrhage. And Viz.ai, which is an AI company, has developed, they typically have software that they use for mechanical thrombectomy to automatically recognize large vessel occlusion. But they have another platform called Viz.ICH. And I think this is really cool. So for any of the neurosurgeons out there, or any of the interventionalists, or anybody that are trying to build a program, I think this is really cool. So you can put this software on your CAT scanners in your hospital system, or wherever they'll let you put it. And the Viz.ai guys told me that probably around 7 to 10 minutes of an ICH being identified by their software on a CAT scan, you will get this text message on your phone that says, patient at so-and-so hospital has a hemorrhage. It immediately does the volume calculation, and then that there's a hemorrhage in your hospital system. The other, I think, amazing thing about this is that you can put your whole team on this. And so as someone that wants to help patients and provide a service to stroke patients, instead of waiting for the ER physician to get radiology to read the report, to call, to basically then to get on the phone, and to call me when I'm sleeping, to wake me up, and I get on the phone with them, we're wasting time here. So if I get this on my phone, it goes off, I can look at it, I can hit a button, call either the radiologist, the emergency room physician, and say, hey guys, listen, I saw you have an ICH in your hospital. I've already sent the helicopter. It's coming for the patient. Thank you so much. That patient will be over here in about 10 minutes. And we can prepare the operating room, or we can reverse their anticoagulation. We can do a lot of things. So I think this is where the field is going. This to me is awesome. If I want to build a program and provide good service to my other teams in the hospital. So I want to show you what happens when things all come together. Okay, so this is a 62-year-old lady. Her name is Kathy Alexander. She's given me permission to share her story with everybody. Kathy was visiting Cleveland from Columbus, and she was walking around right up the hill here in Cleveland Heights, which is just east of downtown Cleveland. And she developed a severe headache, had difficulty speaking, and started developing weakness on the right side, to the point where she was basically paralyzed by the time she got to us. We luckily had the mobile stroke unit rolling around, and the mobile stroke unit was called. It picked her up, and it's not this scan, but there was another CAT scan that was done on the mobile stroke unit that they sent to us, and we saw that this hemorrhage was there. So that they diagnosed a hemorrhage in the field on the side of the road. Okay. So we were notified that this thing was happening. We basically set up the operating room. I was able to call her husband, who was actually getting on a plane, and I talked to him before the plane took off. And I said, listen, we got to make a decision right now. We think we should do this minimally invasive technique. And he said, go for it. Do what you got to do. I'll try to get off this plane, but he wasn't able to get off, so they closed the door already. You guys know that. So he had to kind of be on the flight. And anyway, we put a ventriculostomy in because she had intraventricular hemorrhage, but we got the operating room ready before she was even there. And when she showed up, we took her right to the operating room after the ventriculostomy. We had the hemorrhage out in 4 hours of her symptom onset. And I'll never forget this as long as I live. When she went to the operating room, she couldn't talk and was paralyzed. And as soon as she got back, the anesthesiologist took the tube out, and she immediately started mouthing words and said her name. And I was like, "Whoa, that's crazy." I didn't hear her talk before. And within an hour, the nurse called me and said, "Look, this is amazing. She's actually lifting her arm up a little bit already." I was like, "No, that's ridiculous." I went up and saw her, and sure enough, she's lifting her arm up. And she left the hospital totally normal on post-bleed day 7. All right. And we weaned the ventric after the hemorrhage, and she returned to work shortly thereafter. And this is a picture. This is the last Christmas card they sent me. There's her on the right-hand side with her husband. She is such a nice lady that she actually talks for NICO now. I know the NICO guys on the line here probably have met her. She goes to some of the NICO meetings and talks to the company about how good their product is and how their product has helped her and her family. So this is what can happen when all the stars align for people. And this is kind of what we're trying to set up here. She's doing extremely well. So it almost brings a tear to your eye. These are some other cases. I can move through these kind of quickly, but this is a patient that had a metastatic melanoma. So you can see there's a tumor here with a hemorrhage, and metastatic melanoma is very vascular. And I show this just to show that we can handle bleeding. So we got down there, we were able to coagulate feeders and remove the tumor and remove the hemorrhage. So that you can see the tumor up here, and then post-op, you see the tumor is gone and the hematoma is gone. This is the patient I just showed you. We also use it for cerebellar hemorrhages too. Instead of making this huge incision in the back of the neck, you can make a little small incision and put the tube down and remove a cerebellar hemorrhage. I talked a little bit about Enrich. I'm not going to go into Enrich too much, but I just wanted to mention it. So this is a randomized trial being sponsored by NICO. It's being primary site is with Emory University with Dan Barrow and Gustavo Perdia. The point of this is we're randomizing patients with hemorrhages from 30 to 80 cc's. And we're using the brain path approach. Either people get randomized to medicine or to surgery with brain path, and we're looking at 6-month outcomes to see if this truly helps people in a randomized fashion. This is an old slide, but we're basically, I think, probably up to 217, 220, somewhere around there before COVID started. We had to put everything on hold. But things are looking good for this trial, and we want to get up to about 300 patients. So hopefully we'll have some interesting results to share on this trial. There are other trials going on right now. INVEST is just a feasibility trial using that Artemis device I talked about before. MIND is another trial that's being run right now. I think Enrich is the largest one that's happening. Integra is jumping into this market too, and they're going to be sponsoring a feasibility trial or a single study registry coming up looking at their technology. So as you can see, industry is kind of jumping in here, and I think the more industry partners we can get into this space, the more physicians that are looking at this and studying this, the more that we can benefit patients down the road. So in closing here, then we'll open this up for some discussion. Hopefully we have some lively discussion here. Where are we now? We started doing this in about 2013, and so we're trying to push this field forward. And so the first thing I'm sort of pushing the limit on is minimal access. One of the criticisms of this approach is that the tube is 13.5 millimeters. It's a little big. So these green brain path tubes are actually only 11 millimeters. They're fairly small. And so I'm starting to use the 11 millimeter tubes for hemorrhages. I've done probably about 5 or 6 cases now. It works extremely well. It's small, so it's a little bit hard to get some instruments down, but you still can get instruments down. We're trying to simplify our visualization. So instead of bringing microscopes in and exoscopes, we're trying to use just our loops so that we don't have to bring in all this fancy equipment. You can just put the tube down, use your surgical magnification to look down the tube and to take the hemorrhage out. I'll talk about the Novus in a second, but the Novus is right here. This is the Myriad. That's that little chomper I showed you before with the aspiration. The Myriad hooks onto this, and it provides a light source at the tip of the Myriad. So now you can light up the base of the tube. So now you've got a great light source on your instrument, and you can use loops. So it just makes it so much more efficient. And if that 11 millimeter tube is too small, you can always upsize it back to the 13.5 millimeter port if you need a little bit more working room. So it doesn't exclude you from doing that. This is the Nova. So here's the Myriad, and now this is the light source that we put on here. And I want to show a video of this. This picture over here is using a microscope with, so the microscope is only at 50% light. And this is the novus in a hemorrhage case. And you can see as we move around here, you can see how well, there's a novus light right there, how well it lights up. And you can see I can remove the hemorrhage very safely and very controlled. And on the right here, this is using novus without any light at all, just the microscope. Sorry, it's a grainy picture. The microscope doesn't do a good job recording when you don't have the light on, but you can see very, very well with the novus. And then watch when we pull the myriad novus out. You'll see how much the light you get from that little LED. Look at that. You can really light up the whole field there. And now it's pitch black when you take it out. So we're working on all these systems to be able to provide a more efficient procedure. So in conclusions, I hope I, showed our story a little bit. I hope I educate you guys on where we are with intracerebral hemorrhage. I want to make sure everybody comes away with this, that there is emerging data that shows that we can get good outcomes with surgical therapy in intracerebral hemorrhage. I think the take-home points are we have to be minimal. Doing large craniotomies for hemorrhage is not working. We know that. We need to go early to prevent that expansion. We need to get a high percentage of safe evacuation. We need to respect the brain tissue. I do wanted to show that we can handle intraoperative bleeding. If I had more time, I can show you we've been doing small AVMs with the brain path tube. I have 5 cases now. One of my friends and partners, Justin Singer in Michigan and Grand Rapids, he's been doing, I think he has about 5 cases he's done with AVMs as well. So we don't fear targeting bleeders with this because we can actually operate. And I think the biggest thing is targeting these lesions to prevent expansion and to prevent that secondary edema. So I'd like to thank everybody for listening, and would love to answer some questions or hear some points or discussions or even arguments if you have them. Thank you.
Dr. Bain, I'll jump in real quick. We do have a question in the chat.
Okay.
The question is, can this be used for aneurysm clipping as well?
I have not done that. I don't think I would. Couple reasons. One, I don't think that, first of all, I think the bleeding that you get when an aneurysm ruptures versus these small lenticular striae bleeders is a totally different thing. It's a difference between a carotid and a small little, sub-millimeter vessel. So I think, I don't think you'd be able to, handle bleeding through that small of an access. And then the other thing is, I don't even think, it'd be very hard to get an aneurysm clip applier down. There's probably not that much room. So I personally would never recommend that. The other thing is we have such good endovascular techniques to do these. I don't think that would work very well.
Thank you. It looks like we have a couple of questions in the Q&A. Are you able to see those?
Yeah, so there's one, it says, aside from the physical pressure, do hematomas have any chemical effects also? And actually, I'm so thankful. I feel like I put that out there. So that is a great point. They do. And I am not a basic scientist at all, so I'm not going to embarrass myself talking about all the chemical mediators here and all the pathways at work. But there are people out there. Dr. Lansing at Yale has been doing a lot of work looking at the blood clots from MISTI patients, looking at the inflammatory cascade that's going on. We have just started looking at, and Chris Kellner is doing the same thing, looking at the perihematomal tissue. We do sometimes take brain biopsy samples to see if people have amyloid or things like that. So we actually have an IRB now where we're actually sending some of that tissue off to look at the inflammatory cascade, to see what cells are being brought into that perihematomal space, to see what chemokines are there, to see what antibodies are there. And then the goal of that would be great is if we know what that environment is and what that chemical or that inflammatory environment is around the hematoma, then potentially what we can do is take that mass effect out initially. Maybe we can infuse a chemical down there that will help prevent any further edema. I guess the other thing too is that, are there some neuroprotective agents that we could use as well that go on? So I absolutely do think there are chemical inflammatory mediators at play here that make this secondary inflammation go on. And then there's another question here. It says, if you get level 1 evidence from one of these trials, how many patients will be operated on ICH in general? So that's a great question. and it kind of goes back to a little bit what I said before. I don't want everybody here thinking that every single patient that comes in to the Cleveland Clinic we're operating on for hemorrhage. We're not doing that. We probably get consulted on about 300 intracerebral hemorrhage cases a year. We have a pretty high volume. I would say we probably are operating on, maybe 15% of those patients, or maybe 20%. We've been enrolling in the Enrich trial for, the Nico guys could probably tell me better. It's been probably about almost 2 years now, and we've enrolled 20-some patients into the trial. So that just kind of gives you a sense of the numbers. But I think if we get level 1 evidence, what that'll do is that'll say, hey, listen, there is level 1 evidence now that people get functional benefit from this procedure. And then I think we will have a better ability to design further trials that will look at more of these different types of indications. So, operating on, smaller hemorrhages, going earlier, lobar, cerebellar, things like that. So I think that it will increase the amount of hemorrhages that are operated on, no question. But a lot of the hemorrhage that we see, if you think about it, these patients are really sick medically. A lot of the consults we get are people that have an LVAD and they're on Coumadin and they have one leg and half a lung and, they're in bad heart failure. These are not patients we're necessarily operating on because we think that that's going to be probably a bad outcome in general. We're trying to find that sort of happy medium where it's sort of a localized clot that's respecting fibers and that patients have the potential for a very meaningful survival. So we're probably only operating, I would say, again, like I said, 10-15% right now. That would probably go up significantly if there's a positive trial. And then another question, not having the bone flap affect walking and understanding. I think this is from the patient that had an ABM.
Yes, it is.
Yeah. So your question is does not having a bone flap on affect that?
Does that affect that? Because when I didn't have it, I don't think I realized what had happened.
Yeah. Well, it's funny. We see multiple things. So I've had some patients that have not had a bone flap replaced for various reasons, whether they had an infection or they just got lost to follow up or something like that happened, or they moved, they didn't have a bone in, and they're totally fine. They're just they have a depression there, but other than that, they're doing okay. I've had some patients, and the other neurosurgeons in the audience have probably seen this as well, where they get this craniectomy syndrome where they have neurological problems because there's too much, maybe it's pressure, maybe it's a CSF fluid disturbance that's there. And I have seen people get better when we put the bone on. I even had one patient that would almost herniate or would almost die because the amount of pressure, his brain would just sink in. We had to put the bone on to get that not to happen. So I think there can be effects from not having a bone in place for sure. It doesn't happen to everybody. So I personally think that in patients that we can take this hematoma in a minimally invasive way and avoid that procedure, I think that's a great thing for patients. It's a big procedure, as you can probably tell us better than anyone. Getting that bone removed and a large incision like that is a large surgery.
I don't even remember getting it removed. It was just, I was unconscious.
Yeah.
I remember getting it put back.
Yeah, right.
But thankfully, I don't have aphasia, so.
Yeah, well, very good. It sounds like you've done very, very well. That's great.
I just started walking. It's still hard though.
Yeah, I imagine. Well, I'm glad you made the call today and are able to talk to us about your experience. Thank you.
Thank you.
Dr. Bain, I know we're a little bit over time. Do you have a couple of extra minutes for the remaining questions today?
Sure, absolutely, yeah.
Okay, so we've got a couple here in chat. The first one is, would you recommend an angiogram before proceeding to surgery, and especially if spot sign is present?
So really, that's a great question. Sorry, I'll pull up my chat here so I can see. Sorry about that. Here's what I would say. I think it depends a little bit on your comfort level. Initially, when we were doing these procedures, when I first started doing them, we were doing angiograms on everybody, and then we got pretty confident on using CTA to sort of see if there's any larger AVM. I certainly would never use this for a large AVM and there was a hematoma there. Then I got it, we were the first to publish the use of this for removing an AVM when there was a hemorrhage. And as you get more comfortable and you start expanding your indications a little bit more, then I think you can start handling, bleeders and things like that. So I would say this. I would say I have not had a case where we've done a CTA and the CTA was negative, that we went in and we ran into some massive hemorrhage or bleeding or something like that. So I personally am not doing angiograms. Now that being said, if it's like, let's say it's a 20-year-old that, has no hypertension, is totally healthy and has a hemorrhage, right? That's going to be AVM. So in those people, I am doing an angiogram. But if it's like a 70-year-old with hypertension and the CTA is negative, we go. I don't do angiograms at all. And I feel comfortable doing that.
Okay, it looks like the next one here is, what is the average volume of ICH and what hematoma would be too small for you to do?
That's a good question. We argue about that all the time. So in our series, and if you look at a lot of the studies that are around, the average volume tends to be around 50 cc's. And in Enrich, we're enrolling, that's a randomized trial I talked about, we're enrolling 30 to 80 cc's, okay? Remember that early study I presented from that there's a sort of that 50 cc cutoff where under 50 cc's, you get functional recovery you can show survival, but not functional recovery. A lot of the reason we're doing this and we're looking at is for functional recovery. So I would say this, if you're looking for functional recovery, I think the sweet spot is smaller. If you look at those other studies like Wang's study I presented and things like that, they're all going 25 to 40. And then on the other hand, though, like you brought up, what is too small? A lot of these patients will just get better if the hematoma is small enough on its own. So the smallest I've done, I think, is been about maybe 18, 20 cc's, something like that. Now that gets into, what if there's a spot sign and you have a 15 cc hemorrhage? Are you going to go operate on that to prevent the expansion? And I don't know that answer yet. If the patient's doing really well, there's a spot sign, I might just do some reversal and wait. So we don't have that figured out quite yet. But I think probably if you start getting under 20, especially at your institution, if it's early in your experience, people might start looking at you like, what the heck's this guy doing? You're too aggressive here. So I think one piece of advice for people starting this in their programs is, have your whole team on board. Talk to neurologists, talk to the surgeons, talk to the radiologists, get everybody on the same page, your neuro-ICU physicians, and then come up with a protocol together that you think is reasonable and stay within that protocol, and then kind of review your outcomes and see what you think. And if you think that maybe there would be patients that benefit, it's funny, when we first started doing this, people were kind of looking at me like, what are you guys doing? You're operating all these hemorrhages. This shouldn't happen. No one does this. And now I get called probably 3 times a week by either our ICU or our neurologist that say, hey, listen, I want you to operate on this because it makes our job so much easier and these patients are doing so well. So I hope that answers your questions. I think about 20 cc's is sort of the cutoff for too small, but I think we should go small for functional. That being said, I would do large hemorrhages too, though, because I think it prevents that hemicraniectomy, all that swelling. I mean, I feel totally comfortable taking a clot out, sending the patient out of the ICU if there's no other issues going on in like 2 days. You've dealt with the hemorrhage. There's a lot of room there. You've dealt with the bleeding source. Why not get them out of the ICU and then get them to rehab within the week? So that's kind of what we're doing here.
Okay, great. So the next one is about IVH. With IVH and casting of the entire ventricular system, can you evacuate hematoma past the aqueduct from the supratentorial approach?
Yeah, I think that I was initially really interested in doing that with Apollo and using more of an endoscopic approach. It's just because we're kind of used to using endoscopes in the ventricular space. I was a little bit, and maybe I'm just not good at doing it, I don't know, but I was a little bit frustrated when I was trying to do interventricular cases, because what I noticed is that we were getting good evacuation of the ipsilateral lateral ventricle and down into the foramen of Monroe into the third. And we would maybe get back a little bit into the posterior third ventricle near the aqueducts, but we would tend to leave a lot of blood behind. And then if there was casting on the other side, A lot of times would have to do a septostomy and go across and do that. And then if you look at a lot of the trials that are out there, even using TPA to clear hemorrhage and some of the clear trials and things like that, there hasn't been a big difference in shunt rate or difference in hydrocephalus and things like that. So I kind of got away from doing IVH cases a little bit. I think, to be honest, I don't think that brain path the NICO guys may take offense to this, but I don't know if I don't think it's a great tool for intraventricular hemorrhage. Intraventricular lesions for sure, for like tumors and things like that. But I think a little bit of a smaller approach. And then, as you probably know, if you want to get back to the aqueduct, you usually got to go really low. So maybe an eyebrow incision would be better to get go back, straight back, so you can get there. But we haven't really focused on IVH much. I think there's a lot of data out there suggesting that may not be the right thing to do.
Okay, the next one is about thalamic hemorrhage. Would you operate, and which route would you use to access?
Yeah, so it's interesting. When we were talking, we have done thalamic hemorrhages, and Gustavo Padilla, who's one of the PIs for the Enrich trial, he's done a fair amount of thalamic hemorrhages. His theory is that they do well, they just take longer to recover after surgery. And so we're not doing them in the Enrich trial just for fear that they would kind of pollute the other data, meaning that it would just take too long to get better. I would say that I think that the thalamic patients do worse, kind of like that hour paper I showed. So we will do that occasionally if there's a lot of mass effect, if we feel like parts of the thalamus are spared and there's just more mass effect on the thalamus that's causing the deficit. We tend to use a posterior approach to the thalamus, like superior parietal lobule approach to get there. I know there's some controversy about using that approach or not, but that's what we've typically done. But to be honest with you, I am not doing that as much. We're doing more sort of anterior basal ganglia, lobar, than thalamic. Maybe that's our next study that we do.
Great. So it looks like we have one more question here. This one's kind of a story involved as well. So this participant was part of the MISTY trial. It looks like the institution had a MISTY subject with a 60 cc bleed with IVH also present. The patient ended up with near 100% clot removal and had a significant wash through of CSF from the ventricle. In the end, the subject reported his status as better than before the bleed, and his recovery was excellent. So the question is, do you think that a final flush with CSF potentially could reduce the inflammatory response?
Yeah, potentially. I think right now I don't even know potentially what that inflammatory response is. We see it's very variable. If you look at some of the MISTY data, not all patients were getting this inflammatory response. We have some patients that, I'm sure you guys have seen this too, where 5 weeks out, they're still having edema from this hemorrhage. I remember I did a brain path evacuation. I think it was like a 4-week after the hemorrhage happened, because there was all this crazy inflammation that was going on. So I don't know the answer to that. I think we do irrigate out a fair amount to get all the mediators out. So that may be a really, really good point. Maybe I think what you're saying is right, in that we have to get that hemorrhage out. And I think any hemorrhage you're leaving behind has the potential to create inflammation. So my take on that, though, I think that you got the hemorrhage out and you did a good job getting all those inflammatory mediators out. That's why that patient did well. But yeah, that's a great point. Again, maybe that's, I would love to have, an irrigation solution we use, or CSF that flushes that out. And then also, I would love to have some neuroprotective agent or neurorestorative agent or anti-inflammatory that we could use at the time of surgery that would take care of that as well. So I think these are all great questions. I wish I knew the answer to.
Well, thank you. It looks like those are all of our questions at this time. So if anybody else has a question, go ahead and unmute, type it in the chat, add a Q&A. This is kind of the last opportunity for that. Before we close out, I do just want to say thank you once again to all of our participants who joined us tonight, and especially Dr. Bain. Thank you for being here and sharing your experience. Also, a quick thank you to Cleveland Clinic for loaning us Dr. Bain for a little bit of time here. Thank you to the NICO Foundation and NICO Corporation for helping organize this. And with that, I think we'll wrap up for the evening. So everyone have a wonderful night, and thanks again.
Thank you. Thanks, everybody.